what I wanted to communicate with you now was not so much we've talked about what we're doing, but I wanted to communicate doing this research, what personally I've learned over the course of the last years. What I wanted to give you a little bit of insight of the things that may be of interest. So I've mentioned the fact that especially since this cornerstone publication from the registry, we're actually out there. So there's not a single presentation, not a single talk that is happening in the world today where our numbers are not being quoted. And that has been important because that has given us, or given me, leverage to organize international collaboration. So I organized in the end of June this year in Bordeaux a meeting with international experts. We had what we called a think tank about Fontan. The idea being we have a growing population of people with a Fontan circulation. So the estimates today is that there are there are probably 50 to 70,000 people with a Fontan circulation alive throughout the world. And they're doing much better than expected beforehand. And so what about starting to do what we need to do to give all these people the longest and the most fulfilling life possible? And what we want to is not finding ourselves in the same situation than now, wishing we would have done a randomized trial about warfarin and aspirin 20 years ago, a trial about ACE inhibitor 20 years ago. Let's do now what we will need for 20 years from now. And I had my personal agenda, and that's why I organized these things. My agenda was on the second matter. So we divided it in four sessions. The first one on end organ lesions, focused a lot about liver. The second one was risk stratification for death, because as a surgeon, that's what interests me. There are things we can do, drugs or operations or machines, but how do we identify who would benefit from that? So we need to know where we stand in how well our Fontan is functioning. And we have only very gross tools at the present time. How do we do the best Fontan? What before Fontan? There are things to do to have the best possible outcome 40 years later. And then talking about transplantation conversion. And what we got from that meeting, that was very interesting. There were people from mainly North America and Europe and Australia. The thing is that we want to build up a risk scoring. So what we want to do is we're going to put all the databases together and get all our data and build up something that has been done for heart failure. So for heart failure, if you have coronary disease or you have a failing heart as an adult, you can take some parameters and you put it in a database, and then you get a scoring and you know where you stand. And following your scoring, you know, okay, the prediction of survival I have is about, 10 years, 9 years, 15 years, whatever. And so we could do that for the Fontan as well. So we find out 5, 6, 7 parameters, we score them from 1 to 5, and then we get a number, which means that right now, if we want to make any intervention, any drugs, when we give the drugs and all we can do is say, okay, we see how many people have, face, unfortunately, death or transplantation. And that's the only hard endpoint we have. The problem is that only very, very few have, death or transplantation. So if we have a scoring, we said, okay, we have a population, the average went from a score of 6 to 7, 6 over 10. We do this intervention, and then they go to a score of 8 to 10, so they're much better afterwards. So just refining a little bit the Fontan circulation. So that's it's going to take a bit of time. Another data we had is that we discussed about how we investigate Fontan failure, and I think that I've learned a lot from that. I didn't realize before I talked to these experts what is going on. So we have discussed, and Kirsten explained that if you want to know how well a Fontan circulation is working, what you need is to know the pressure in the central vein and the pulmonary arteries. If your heart is failing, this pressure will be higher. And normally, she quoted a number of 12, 15 to 20 would be all right. But actually, what we do to measure this pressure is probably completely erroneous. And it was a doctor from Chicago who has the largest experience with Fontan failure who said that. We're taking the pressure in a cath lab on a patient that is fully anesthetized, and so when you anesthetize, you completely relax, your blood pressure is down. After one night where you haven't drank, so the volume inside your body is much less, so you're much more concentrated. You're lying down instead of being standing up, and you're completely resting, you're completely flat. While what we should do, she was saying, we should probably look at patients who are awakened, or at least at the minimum, make sure that your blood pressure is the same than when you were awakened. We should measure this pressure fasting as you are, but give a volume test. And so how does it move when you give volume inside your blood? And ideally, we should test it on exercise, because even a patient, somebody who's got a Fontan circulation and who's got a pressure on a cath lab now of 12 to 14, you put them on a bike, the pressure into in the veins will get to 25. Some people even say it goes to 35 millimeters of mercury. And over the course of the day, you're moving, and yes, when you're asleep fasted, it's going to be 12. And maybe for the rest of the day, you're at 22, 25. So there is this concept of the pressure load. So if you look at arterial blood pressure, hypertension, we are now realizing that what is important is not checking once into the GP, your blood pressure in your arms. What is important is the pressure load of the course of the day. So 24-hour blood pressure monitoring. What is your blood pressure over the course of the whole day and night is actually what counts on your risk of cardiovascular disease. It's going to be the same for the Fontan population. What counts is the average central venous pressure over the course of the day. I think what we're going to need at some stage, we're going to need some volunteers to do invasive pressure measurements. So having maybe a catheter put for 24 hours and running around and do all the things you're doing to see, hey, what it is over the course of the whole day. I think that's what we're going to need. Okay, Brian, yep. The thing that came out as well is that we'll talk, and I'll talk about heart transplantation. We had some talk about that, but we know that heart transplantation will not be the final option because we don't have enough hearts, and we've talked that in the previous education days, a machine coming our way. I have a personal ideas. Unfortunately, I've lost the medical engineer that had promised me to work on it, and the budget that the Victorian government had promised to give, but because change of politics, whatever. But there's one guy, Mark Rodefeld from Indianapolis, who's the most advanced now. He still has received a fund from NASA. And as a group of international experts, we said we're behind him and we'll try to develop that. He's developing this little device here, and it rotates. It has a cross shape, and you put it in the middle of the Fontan. It rotates. It pumps the blood from the SVC and the IVC, and it's injected into both pulmonary arteries. I don't know if it's going to work, but it's clever, and it's on the point that I had the device in my hands. So he thinks that within 1 to 2 years, we could have something to try in the first animal. So that is coming our way, hopefully. It still has to work. Huh? But the beauty of it, though, is that, and I think we were on the same page, that he's putting a device that even if it stops working, the circulation would work. And some other people have made that work, that if you put a diverter, something that give orientation to the flow, in the middle of the Fontan circulation, it gives you actually this nice laminar flow that you want to have. So we've talked about the studies that we are currently doing, and one study that we've introduced, and hopefully I hope will be fun, is introducing a healthy lifestyle program centered on exercise training for the whole population, and we try to have it as a model of care for any chronic pediatric conditions going to the adulthood, and some program that we'll introduce to from 5 years old to 40 years old, and we'll see if that works. We have currently a partnership grant, and that's a very important component supporting the registry so far. In this partnership grant, we're trying to investigate how best follow up people with a Fontan circulation and what kind of treatment to give. And I'll give you some highlights from the things we've done already. One of the things is we've started working with health economists, and Kim is there and has been helping to generate this paper. Because we have good survival data now, and I invite you to consult the Fontan Registry data, we are seeing one thing is that the people have said that when you have a Fontan, for many years they say it's going to work for 15 and 20 years and then everything will fall apart. Well, we're finding out that even for the old version Fontan and the recent version Fontan, there's an absolutely constant rate of attrition. There's no sudden drop in survival or in functional status. So we can make prediction, and so now we can say that by 15 to 20 years from now, the population will double. Can you imagine? So 50, 70,000, that's 100,000 people throughout the world. Today, there's the double number of people who have a cystic fibrosis in Australia than a Fontan. In 15 years, it's going to be the same number. So another little pearl we got from this type of work is coming from this study that is now submitted for publications. We looked at the cost of having a Fontan by looking at the cost to pediatric hospital from birth to 18 years of age. And you may wonder how it can help you. Listen, I thought it was an expensive matter. Actually, I thought that all the costs were all these expensive operations, this month of hospital stay before the Fontan and at the time of the Fontan. Actually, I'm quite cheap. On a total of $490,000, up to 18 years of age, only about $250 are taken by all the surgery and all the time before Fontan. So even the time after Fontan is costing a lot. So it's costing a lot to the health system every year. Then we look at what was costing. Yes, cardiac surgery was, and cardiac interventions and cath lab was an important cost. Then we have an important cost of operations that are not cardiac, and that's what we're investigating. I don't know what they are, I don't know what it is, but it's going to be interesting. Then we look at non-medical costs, non-intervention costs, the medical costs. One of the highest posts for medical costs was ENT, and ENT, why? Because of dental care. So that was a very surprising finding. So I go to the head of dentistry in the Children's Hospital, and he said, of course, we've known that for years. You guys, your patients, they have so many teeth problems. They have decaying much faster than anybody else. And so what are the hypotheses? Why would that be? Well, he said, I was thinking that, you give more sugar to, these people because, you're a bit softer, they have a heart condition, hey, come on. The other thing is, he said they can have a different oral flora. The bacteria in the mouth may be different. We talked yesterday again about it in a partnership meeting, maybe, other factors, nutrition, acidity. And then when we talk in Bordeaux to this expert meeting, there's one of the most world experts from Philadelphia. He said, you have elevated venous pressure. All of those with a Fontan circulation have dilated lymphatics. This little channel that drains the water, the lymph from between the cells. And you're leaking fluids through your gut, and so you're losing some lymph cells that are giving you immunity. And so, of course, you have a different oral flora if you have a Fontan circulation. I'm not sure he's right, but that's something to investigate. But the beauty of that is that when I talked to the head of dentistry, he said, Well, it's stupid because it's easily preventable. We see all of these kids at the age of 4. We should see them at 2. Give them all your kids at 2 years of age, and there's going to be no dental issue. So not only, this cost analysis bring us to things that will immediately affect care. We've talked largely about aspirin, warfarin, ACE inhibitor. We've talked about it. We haven't made our mind about what is good, but we've identified patients and we've said it, we're going to investigate whether it's useful or not. Fertility and pregnancy, we've talked about, and I think that we've shown that even if it's difficult, it's possible. Heart transplantation, we had a big paper on heart transplantation, and the things that we demonstrated is that heart transplantation had a bad reputation in Fontan because we know it's more complicated. You have a lot of difficulties, technical, because of the lung arteries have been operated so many times, general condition of the patient, the liver issue as well. And we've demonstrated that actually the survival for those in the red line here who have a transplantation, and Fontan was the same than the people who have a heart transplantation and 2 ventricles. Those who had need for heart transplantation before the Fontan were doing a little bit worse. So we're proving once again that it's as good. We demonstrated at the same time that there's sometimes an issue for access to heart transplantation, and we discussed that in Bordeaux as well. There's a difficulty in some countries, in the UK, North America, for the Fontan population. They've made in the North America now a list of criteria to access and how quickly you can access to heart transplantation. And when you have a Fontan, you don't have 2 ventricles, you are at the bottom of the list because you can still walk around and you can be, you can be really as sick as the highest degree, but with the way they've organized the listing, you don't get access to it. And we've seen some discrepancy in access in Australia and New Zealand, and that project has, I believe, helped to solve that issue. A little thing that I thought was interesting is that's a small work done by a student. Common atrial ventricular valve. Normally you have 2 valves in between the collecting chamber and the pumping chamber. Some people have a common atrial valve. And it's known that this valve, even when you have a 2 ventricle, when you have a single ventricle, you know that normally it's a risk factor for adverse outcome. And even if you have 2 ventricles, this valve tends to leak. So there is no data about what happens in a single ventricle circulation. When you have a Fontan and this common AV valve, what happens? And so we looked at the incidence of failure of the valve over the lifetime of a person, and we had 114 patients where we had follow-up and different echo with times. We see that a quarter of those reaching Fontan, so these are people who have gone to the Fontan, so a lot more before Fontan had issues with their valve, and that may have impaired the capacity to reach Fontan. But a quarter of them needed an operation before Fontan. But actually, the Fontan is about 5 years of age, and after that, a lot more still continue to see a failure of their valve. So their valve starts leaking, but they don't have an operation. So you're going to say, oh shit, another round of bad news. Actually not, because it shows us a few things. It shows us that maybe, and that's something to think about, I don't say that's something that needs to be done, but maybe the patient's developing failure of the valve, leakage of the valve after Fontan, maybe we should have a closer look at these ones, because maybe we should do something about it to prevent other things to happen. And then if we see that these valves are prone to failing, we have developed in the recent years, more sophisticated operation to stabilize this valve, and maybe we should start working on preventing failure of this valve. So yes, it's a bit of a bad news, but it's actually good news because these are things we can work on. And these are unique data. Plastic bronchitis, protein-losing enteropathy. This is leakage of protein in the gut or in the airways. So there's small work done by a student showing that actually the outcomes with these terrible conditions that chicken face rarely after Fontan is actually much better than 10, 15 years ago, so we're doing better. And in the recent times, my colleague in Melbourne, the head of the department, Christian Brizard, has developed an operation where he's isolating the blood coming back from the liver. Instead of going into the Fontan circulation, it directed it back towards the heart, decreasing the pressure. All the rest of the body is subjected to high pressure, except from the liver. And it seems like it's a promising operation. 2 patients only so far, but maybe that's a new way for treating one of the complications that is seen sometimes with the Fontan. What are the news? Well, there is one drug that is likely to give improvement to the Fontan circulation. And I cannot tell you which drug it is because I'm bound by secrecy, and I've asked, but I cannot say. But I can say already that there's a trial that will be taking place early next year, and you'll be invited to participate to this trial. And overall, all the registry committee thinks that's the best avenue when it comes to drug to improve the Fontan circulation. The beauty of the registry is that that's going to be a worldwide trial, but in Australia and New Zealand, we're going to have access to this drug 2 years before North America and Europe because we organize as a registry. And the beauty of having a lot of us participating to this trial, maybe we can continue the drug beyond the 1 year that is planned, because that may be something that may be good actually for the long run. That's the best avenue when it comes to drugs at the present time. We'll talk about exercise this afternoon, and I've mentioned we're going to launch an exercise training program. But we need you to participate, and we've said it more than enough today. The thing that I'd like to insist on is the fact that when you have chronic, severe condition, I'm talking about cystic fibrosis or cancer, you will see that a lot of the people with this condition participating in trials. I think nowadays, in this situation in Australia and New Zealand, if you are not in some studies, there's a problem. I mean, you should ask yourself questions if you're not participating to something. And I'd like to quote John Fitzgerald Kennedy in his inaugural presidential address, this famous say, ask not what your country can do for you, ask what you can do for your country. So ask not what you Fontan can do for you, but ask what you can do for your Fontan. I think I'm very serious. I think we're in that situation. Thank you very much.